been my area of research for 12 years now, so long, I won't cuss, long time. And what we'll show you now, right now, is a hip subluxation. So there is a hip subluxation, so I believe there is. And so we can have, like all manipulation, you can have neurophysiological effect, and you can have mechanical effect. So what we're looking for, particularly with some of the runners, is the subluxation, and then we can deal with some of the other stuff as we go along, depending on what we see with Dave. And so that's what I was doing this on, and I call it a UFER. That's what you heard in the video. It's called a UFER. It's my own name. It's called unrestrained femoral internal rotation. And so where it's through loading, the femur has, you know, internal rotation. We see that all the time with athletes and steps. And this is a fixed moment. You know, most of the early work, you know, 12 years ago was saying that everything's coming from the ground up, so from the feet up and not from the hip. And so I was really one of the first people that was looking at the hip as a primary incident of a problem. And then what you started seeing is lots of athletes, and you see this, why I'm looking at runners, and I see lots and lots of runners, and Colorado has lots of runners, is running is the extreme form of a single leg stance, or unilateral loading. So what we'll first look at is just how that limb loads, and that's part of what he's asking me to on the video. Let me have you loosen your belt if you don't mind as well. We're not going to do too much, but I don't want to be fighting your pants. Okay, so you're going to have your back towards your legs. Okay, so when I'm looking at the hip, which knee is it?
Left.
So the first thing I just want to do and get a general assessment of how well they're loading through their pelvis. Now remember that the hip joint's the largest loading joint of the lower extremity. So lumbar spine, joints like this, hip joints like this. So we want the majority of the weight bearing to be on the hip joint. So the couple of big loading joints in the lower extremity are the hip and the talocrural joint. So you have to have stability of those two joints, and you have to have centering of the femoral head for you to be able to do loading, which is single leg loading, like single stance, or more particularly in running, which is single leg loading 15 times your body weight. And so when I'm looking at the hip, if we can, you know, I never exclude anything, so I wouldn't be excluding the feet or the pelvis or the TL junction. But if we're just looking at the hip, I'm just going to take my hand, put it on the iliac crest, and we're going to see where this trochanter is in relationship to this whole ilium. And you can see how far forward underneath the ilium that trochanter is. All right, so that's one of his strategies. Turn around and let's go this way. Let's turn you all the way around. If we come to this side, see how much more centered that trochanter is? And turn back, let's go back this way. And so just stand there comfortably. Okay, so a couple other things that he does in his strategy is he's actually not just, he's fixating in femoral rotation. So you can see, we'll look at that in a second, but there's the femoral rotation. But not only is he in femoral rotation, can you see the lower body? So the fibulas and internal rotation. And so this, you know, you could say yes, well maybe it's the foot, maybe it's an overpronated foot, but at the moment we're going to take a look at where all this is coming from and see if it's coming from on high. So when we see that right off the bat under that the trochanter is very far forward, then remember the trochanter's like that fin and it's spinning forward if that leg's in internal rotation. So in a neutral weight-bearing stance, that ball should be centered in the acetabulum, you know, right underneath. And so that trochanter should be very well centered. And so that's the first thing that we're looking at. The second thing we're looking at is, go ahead and face that wall, is I'm just going to have him forward bend. A lot of muscle tone going on there. Just forward bend. And what we see with forward bending, come on back up. I guess I'll have you back towards us again. Is when you forward bend, your pelvis goes posterior, yes? It has to, right? Everybody? Yeah, pelvis has to go posterior. Your whole upper body mass is going forward. Your pelvis has to go posterior. That means your acetabulum should go posterior. That means your hip should go posterior. If we look here on this trochanter, go ahead and bend forward. That goes backwards. We look here, it goes forward. All right, so what's happening is, so as he's going backwards, his femur's going further into internal rotation to take up loading. So that's one thing we look at right there. The next thing we look at is a small squat. So let's have you do a small squat. And come on back up. When you squat, your butt should go backwards, your acetabulum should go backward. That means your trochanter should go backwards. Can you see that spin? Turn to this side. Nobody's speaking to me anymore. Okay, squat. Squat. Turn to the other side. Squat. Squat. Okay, now if we turn forward, and we did a squat, now it's interesting, most of the time you can look at the patella and see where the patella is heading. His femur is going into internal rotation, but his patella is not. Okay, so we're starting to see, if I didn't know better, my guess would be we have a severely tight IT band on this lateral side. It's pulling not only at the patella, but it's pulling on the fibula. All right, so it adds attachment. And that part of that is when you single leg stance, so stand on your right leg. Okay, relax. Okay, when you, let's say instead of single leg stance, you should single leg load. When you single leg load, you should be like that, right? Foot, knee, hip, trunk, no lateral shift, no internal rotation. All right, right leg, not bad. Lock your knee, he's got a little shift, he's got a little internal rotation moment. Okay, left leg, got a very large internal rotation moment. That's not even holding him up very good, is it? Okay, and so when he left loads, what he does is wow, I'm a lot shorter without those. Okay, when he left loads, he has to do this. He has to bring his leg in, and he has to do this. Okay, so he internally rotates and he has to lean. So he's going to lean. So as a runner, he's going to lean on his IT band all of the time. Okay, so that IT band, so even though he's getting femoral internal rotation, his patella is actually going lateral. So that IT band is pulling that patella, and it's actually over-stabilizing his fibula. So his ankle will eventually break down because the fibula is a syndesmosis that has to shear up and down with movement, especially running motion where you're landing just on your leg. So that's basically like right, off the bat. Turn your back towards me, sorry. So right off the bat, he has what I would consider a EUFR. So that's a EUFR right there. So there's a whole bunch of other tests that we can do for the EUFR in standing, and I think we don't need to do all of those right at this moment. Nope. So then you're just I'm gonna take a look at the joint, lay up on your back. Okay, so there's a difference between stiffness and subluxation. So in the subluxation model is it's pathomechanical, so it falls out of the normal joint range. And so what I'm concerned about, what I've decided with everything that I've looked at, that there's only one really important feature, and that is internal rotation at 90 degrees. So internal rotation at 90 degrees, that's any pain with that? Feel that?
Painful, but I can tell the quality just feels. I mean, this one's feels a little better than the other one.
What kind of knee pain are you having?
Pain how I get predominantly started was basically posterior kind of hamstring, posterior lateral knee coming into the fibular head.
Okay, so this actually, the true subluxation is hit it at 90, hit the anterior inferior rim of the acetabulum. And so we're not quite hitting that acetabulum, so he's certainly got some stiffness into that trochanter, but it's not as bad as some of the subluxations that I've seen. So the other thing we're looking at, you're going to have to come closer if you want to see this, this is an odd thing that everybody likes to argue with me about, but since you're not speaking to me now as a class, I guess you won't argue with me. Okay. When we do a log roll, if the femur is centered in the acetabulum, as we touch the anterior part of the trochanter, it actually stays neutral. Okay, see how it's staying back there? And so we're log rolling. So we're just hitting the spin, so it actually doesn't do anything. We've got this euphor thing. See it spin up? Okay, so that just tells you this is not centered, so everything's forward. So as I roll, we're beginning to get into pathomechanics, so it's not within the acetabular framework, it's shifting forward. So it's not, I would say it's mildly subluxed, so it hasn't completely broken down, but that's it. Now, I forgot to tell you that one of the things that I decided when we were standing is when you know it's the foot or the knee or the hip, is the sooner the moment occurs, the more likely it's a hip. So if you're on the hip and you begin to weight shift and that trochanter spins, it's the hip. You haven't had enough time to adapt from the foot all the way up. And the second thing that you see is when you say, let's stand on one leg, and somebody goes, okay, because you should be able to stand on one leg. It's a non-thinking process, and when you have to have a motor strategy to stand on one leg, then it's the hip. It's not the foot. Does that make sense? Okay. Yeah. So those are the two big things. And then the last thing that I look at is lay on your right side. And bend your knees up. Can I just have a pillow? So the reason I have a pillow in between that knees is this is essentially the loose pack position of this hip. Okay, so slight flexion, slight external rotation, a little bit of abduction. So that's that loose pack position. And if we take the trochanter in the loose pack position, so where we're in the neutral zone, we should have the most mobility. And that's his mobility at his trochanter. Okay, so that's not good. Flip on this side.
Are you gliding that, Gail, like anteriorly?
Just wiggling it.
Just wiggling?
Watch this one.
Okay. Just trying
Okay,
to assess.
because you should have neutral zone mobility, so it's just a wiggle. Okay, so it's not, we wouldn't consider it a glide or anything else, but you should just have, if you're sitting in your neutral zone, just like you're going to a humeral joint, I should be up, have some neutral zone mobility. And so he's got it here. He doesn't have it here. Throwing money at us. Anybody want to feel that before we do something to it? Yeah. See it right now.
I don't know what you're doing.
And I also have no like PCL. Which is fun.
Yeah.
Oh, this doesn't have a high-low. Okay. So, there's lots of different ways. I have 7 at the moment different ways to manipulate that. This one that you learned from Jim and you guys learned is the easiest to start with. And so we're going to fix the ASIS, get my thumb
The other side, right?
Yeah.
The stuck side was left, right?
Yeah.
Oh, flip over there. What are you doing for me, Dad?
Here.
You're going to whack that one.
Dave's in there like, I need treatment on both sides.
Smack is just always so kind of gratifying. Is that wrong?
Feels so great.
It's on video.
It's the real reason why I wanted to do this, Gail.
After hours.
That's why Gail was like, does anybody understand?
Okay, I'm gonna grab the ASIS. And we're gonna do it 3 times.
Oh, we did.
Okay, I
Right?
think I got it. Back.
Sorry, check the other side or?
No.
That's you.
That's nice.
And feels different.
What's the difference when you
Equal
do
to
the
those.
same? Yeah.
On the side, the other side.
So long accident rotation, it's the same thing.
How long will it stay the same? What? Did somebody ask me a question?
No.
No.
I was thinking it.
What?
How long will it
How'd
stay
you do
like
that?
that?
I will stay like that for.
Cause I got mine fixed here, but then it went back.
Okay. So you have to have some motor strategy. You have to change your strategy. So most runners have a hip that have this have a hip flexor strategy, and because the hip is anterior to the center of the acetabulum, that's the only thing you can use. So until you down train the hip flexors and you up train the hip external rotators and the glute max. So you actually can't just manipulate, you actually have to have a motor strategy.
Oh, okay.
But I have had people that fly in from other states that are runners that only have to fly in once a year. So it depends on if it's subluxed or if it's a motor strategy, right?
Yeah.
So they're 2 different things. So you definitely have motor strategies where people are weak pelvises and they have to internal rotate. We see that all the time, right? Weakness through the back of the hip, and so they always internally rotate. And that's different than a subluxed hip that can't do anything else. Okay, I want to just open up if I can on this very, very high table. Are you okay?
Similar way to do things.
Are you okay still?
Yep.
Gail, usually when you do the internal rotation and flexion, is that painful at the hip? Or not necessarily?
It's usually painful in the groin. Going back. Let's see.
Dave, does your hip snap at all?
Mm.
Nope. Right side.
Other one.
You okay?
Mm-hmm.
There it goes.
Oh yeah, she was holding the, I guess he's
Back.
That's a lot more range.
Okay, let's have you stand up. Let's look so let's have you stand on your right leg. Small squat.
Yeah. Oh, it goes back. Yeah. It's very squat, the trochanter and everything. Remember, it's supposed to go back towards the, where it wasn't. So now,
Can you feel that difference in your ATV? Not really.
no, not really.
Stand down on this one. Okay, so what we need now, so that's better. So the hip is doing better and it's immediately better. Let's just see if it looks better. Let's go sideways. And that one. Good. Okay. Now, so the motor strategy that we have to do, turn around and face me. So the first thing is you have to learn how to hip fold. And so the fold is to be able to stay in neutral, or what I will teach them is to be an external rotation on that side. So I want you to actually put your weight on your inside heel on that left leg, and that you just have to really fold as you come backwards. And let me have a chair here. Oh. Okay, turn back towards me. Sorry, back towards me. Okay. So what you're going to do is put your weight on the inside foot. There you go. I'm going to take you back. There. Come on back. So folding is actually dropping in through here. And you got to down ramp the front of that hip. Can you feel that hip wanting to
I do.
pull forward? So you got to drop back. Now, well, so you got to bring that hip back in the acetabulum as you squats. Now, I've decided that the very perfect squat is put your weight on your heels, and you should have a vertical tibia. So back here is where we want you to be in your squat. There you go. And see, that right there is going to start pulling on that IT band and helping you stretch out. He's actually doing really good. You're a good squatter. You didn't start that way, so that's probably what I'll have you do. So, is it this knee or this knee?
This one.
Okay. And I just want to look at one little thing on your side. Just
Side?
with you. Right side. Yeah. I'm wearing down. My voice is dying. You can ask me any questions. I don't know what else you really want to know at the moment today. Sorry. There it was. Okay, stand up. Let's take it. Stand on your left leg. Looking better. Down. Weight on your medial heel. Stand. Stand.
Single leg.
Yep. There it is. That's your exercise, medial heel. One more. There you go. Okay. I'm done.